Today. My name is Bethany Doherty, and I am a program coordinator for OneOp. It is my pleasure to welcome you to today's session on counseling military families with eating challenges. In case you are joining us for the first time, I would like to give a brief tour of our webinar platform so you can find your way around. Hopefully, you are currently able to view the slides we are sharing. If you are unable to see them or have any other difficulties, please email us at contact@oneop.org for tech support. As some of you have already done, we look forward to having you join us in the chat pod for conversation and questions. Several people have already shared the location they're joining us from today. Please continue to do that if you'd like. To embed the chat pod so you don't miss any links or conversation, simply place your cursor over the shared slides. You will then see a toolbar pop up across the bottom of your screen. From there, click the chat bubble icon. When typing questions or comments, please be sure to select everyone from the response options drop-down menu so everyone can view them in the chat pod. My OneOp colleagues will be monitoring the chat pod and providing links to webinar resources as the webinar goes on this morning. Please note that the slides and resources are available for download on the event page for today's session. We will be covering continuing education information at the end of the webinar, so please stay tuned at the end if you are interested in continuing education credits or a certificate of attendance. Closed captioning is available for this webinar. You can turn on the subtitles via the Zoom toolbar. If you need to step away from today's webinar at any time, please note that a recording will be available for review within 2 business days on the event page. Thank you for joining us as we continue our partnership with the Defense Department and the U.S. Department of Agriculture to expand the readiness, knowledge, and networks of the professionals supporting our military service members and their families. The views expressed in this presentation do not necessarily reflect the official policy of the Defense Department, U.S. Department of Agriculture, U.S. government, or OneOp. The mention of any entity or product is for informational purposes only. Today, I am very pleased to introduce our speakers, Captain Brooke Gunnarsson and Captain Ryan Farley. Captain Brooke Gunnarsson currently serves as a holistic health and fitness, or H2F, performance dietitian and nutrition educator at Fort Campbell. She continuously seeks ways to intertwine nutrition with mental health. She earned her bachelor's in psychology from the University of North Dakota and a Master of Arts in psychology with a child and adolescent focus from the Chicago School of Professional Psychology. Captain Gunnarsson also holds a Bachelor of Science in Dietetics from the University of North Dakota and completed her dietetic internship at the North Dakota State Psychiatric Hospital, where her work focused on how mental health impacts eating behavior. She has focused on mental health and nutrition practices for over 10 years. She plans to complete her doctorate in clinical nutrition from Rutgers University in 2026, and her DCN research focuses on collaborative practices between registered dietitians and mental health professionals. Captain Ryan Farley currently serves as Assistant Chief of Food Operations at Walter Reed National Military Medical Center. Captain Farley earned his bachelor's degree in dietetics from Montclair State University and completed the dual Masters of Nutrition and Dietetic Internship program at the College of St. Elizabeth. He has worked with eating disorder patients in some capacity for over 5 years. Before commissioning, he worked at a combined inpatient and outpatient eating disorder treatment facility in New Jersey, where he gained experience in the treatment of eating disorders from initial diagnosis through sustaining recovery. While in uniform, he has worked specifically as a referral for the Walter Reed Behavioral Health Department for service members and civilians experiencing disordered eating. And I will now turn it over to Captain Brooke Gunnarsson to start the webinar.
All right, thank you very much. Okay, here is our disclosure statements, I just want to say thank you so much for this opportunity, and thank you so much to everyone who is attending today or watching this recording later on. We're going to move right into our learning objectives for today. We will define and recognize disordered eating trends amongst military-connected populations, understand the professional's role in supporting and treating individuals with disordered eating, and identify benefits and resources available to service providers working with individuals experiencing maladaptive eating behaviors. So starting with what are eating challenges? So when we talk about eating challenges in this presentation, we're referring to a broad spectrum of behaviors that interfere with someone's relationship with food or body image, even if they do not meet the criteria for a clinical eating disorder. These behaviors can be seen as seemingly harmless habits like skipping meals, eliminating food groups, or exercising to compensate for eating or to earn a food item. But over time, these patterns can disrupt nutritional status. They can increase stress. They can negatively impact mental health and overall health. Some of these behaviors may also be viewed as normal, especially in environments where food access, body expectations, and high performance are emphasized. This is particularly relevant in military settings where the culture may overlook or even reinforce disordered patterns. And we're going to return to that later on in this webinar. For now, we want to emphasize that disordered eating exists on a spectrum and that individuals can be affected long before a clinical diagnosis is made. These are some of the acronyms that we'll use throughout this presentation. We have ARFID, Avoidant Restrictive Food Intake Disorder, AN, Anorexia Nervosa, BED, Binge Eating Disorder, BN, Bulimia Nervosa, ED, Eating Disorder, MDT, Multidisciplinary Team, and OSFED, Other Specified Feeding or Eating Disorder. So this quote states, any woman who has some form of unhealthy relationship with food and her body, she may be caught in the diet binge cycle, restricting forbidden foods, feeling guilty after eating, or in a semi-starvation state from chronic undereating, fasting, skipping meals, or overexercising. So this quote by Deborah Waterhouse, as referenced in Beyond a Shadow of a Diet, it really widens our lens on eating challenges. It emphasizes that disordered eating is not always clinically diagnosable, but still deeply impactful and relevant to consider when working with military-connected families. These behaviors, like skipping meals or fasting or overexercising, sometimes signal high levels of discipline or that someone's making health-conscious choices. These can be valued behaviors, right? But they may actually signal distress, especially when we think of high-performance populations. So I want you to consider high-performance settings or weight-conscious settings, such as the military environment, which can then extend into the home. The individuals within or affected by these populations may experience disordered eating in less obvious ways. By association, these individuals are part of a very body-conscious culture where success can be associated with leanness or control and maintenance of one's physical appearance. The behaviors that arise in those settings can spill over into home life and may be adopted by additional family members. And so as we move forward, I want you to keep in mind that disordered eating doesn't always look clinical, but the psychological and the physical impacts are real and significant. Throughout this presentation, we'll use both disordered eating and eating challenges to reflect a broader, more inclusive framework for understanding problematic eating behaviors. So these behaviors might appear subtle or even socially acceptable at first glance, especially within military culture or the high performance environment. So practices like clean eating or meal tracking or fasting for long periods, they're often praised as discipline or examples of positive self-control. And similarly, working out to earn a meal or skipping meals to save some calories for later on could be perceived as motivated or strategic. But when we look closer, you might find that these behaviors are actually rooted in anxiety or guilt or excessive focus on food and body control. So for example, fasting without cultural or medical justification or feeling the need to avoid eating in front of others could suggest some deeper discomfort with food. Meticulous food tracking and post-meal shame also point to patterns that are rigid and emotionally distressing, even if they don't meet the criteria for that clinical eating disorder. So this is where I want you to picture your role as a clinical provider and understand how critical that is. You might be the only person that a client feels safe enough to share those patterns with. And so I encourage you to recognize them as clinically meaningful signs, not just healthy habits. These signs, especially if multiple are going to be observed together, could indicate that disordered eating is occurring, and it could signal the need for additional evaluation or referral, or maybe a shift in treatment goals. Okay, so within the military, discipline, self-control, and high performance, they're not just valued, they are essential to success. But those same values sometimes can mask disordered eating behaviors. So behaviors like skipping meals or weighing yourself daily or the meticulous food tracking, that can be seen as admirable, even if they are rooted in that anxiety or that guilt. And so to add to the complexity of these patterns of restriction or overtraining, these behaviors can look like dedication. And service members can actually be praised for these efforts, even when they are harming their health. The normalization of these behaviors make disordered eating especially difficult to identify and to address. And so it doesn't always stop with the individual. In some cases, the family member, especially a spouse or a child, can begin to adopt similar norms. They start engaging in the same behavior. They might start labeling the foods as good or bad. Maybe they start tracking their own intake, or maybe they join in on a restrictive eating pattern. And it's not because they have concerns about their health, but because these behaviors have become part of that family culture. Because these patterns are reinforced by the broader military environment, they're often not viewed as concerning until serious health or emotional consequences emerge. And this can really delay treatment, it can increase stigma, and it can make recovery a lot more complex. Okay, so let's look a little bit more closely at how eating disorder risk develops over time. In a longitudinal study by Rode and colleagues from 2015, they followed nearly 500 girls from age 13 to 21, and they assessed eating disorder risk factors and diagnoses annually. What they found has significant implications for prevention and also understanding how risk factors may unintentionally become rooted in military connected families. So, body dissatisfaction emerged as the most consistent and strongest predictor, significantly forecasting eating disorder onset at every age examined 13, 14, 15, and 16. This indicates that body dissatisfaction is not only present by early adolescence, but it may already be shaping long term risk. At age 14, 5 out of 6 key risk factors, including pressure to be thin, thin ideal internalization, dieting, and negative affectivity, significantly predicted eating disorder onset in the 4 years that followed. This age appeared to be a developmental tipping point where social and emotional changes really amplified the risk. Notably, BMI did not predict eating disorder onset at any age. So in other words, the risks were not about the actual weight. They were about the internalized beliefs, the dissatisfaction, and behavioral coping strategies like restriction or over-monitoring. In military households, where children may be frequently exposed to appearance-focused language, body composition talk, or performance standards from a really early age, these risk factors may develop even earlier or be more deeply ingrained. So a 10-year-old who hears about making weight or sees a parent skip meals or cut food groups out may begin to internalize those behaviors before they even understand what disordered eating is. So let's take a look at a case example. We're going to call her Sarah. She's a 32-year-old military spouse. She's 6 months postpartum with her second baby, and her family just relocated to a new duty station. She's now a full-time stay-at-home mom, and she's caring for 2 young children while her husband steps into a demanding leadership role. She feels intense pressure to bounce back after pregnancy. She compares herself to other spouses who seem fit and put together, and she compares herself to the past version of herself who was strong and energetic. And she worries that not looking a certain way is going to affect poorly on her husband. Her husband is athletic and he's very structured. He logs every single workout and he trains at the CrossFit gym 5 nights a week. He meal preps all of his food on Sundays, and he's currently following a low carb plan to lean out. At home, he encourages the family to eat clean and often scrutinizes the snack choices that others make. So Sarah gradually adopts the same routine. She's cutting carbs. She's meticulously tracking the calories, skipping meals here and there, and jumping back into intense workouts despite still healing from childbirth. She's exhausted, she's irritable, and she starts to notice that her milk supply is starting to drop. She's also constantly hungry after meeting her calorie goal that she set for herself each day. And so now she finds herself binging at night on foods that she has labeled off limits, either while her husband is at the gym or after he has gone to bed. She feels ashamed and she tries to compensate by eating even less the next day. Sarah doesn't see her behaviors as disordered. She sees them as necessary. Her husband doesn't notice anything concerning. He's just chalking her mood up to being postpartum, and he's celebrating her weight loss. In a culture where discipline, body image, and performance are closely tied to identity, this kind of cycle is not uncommon. From a nutrition perspective, several red flags really stand out to me. She's restricting her calories while breastfeeding. She's cutting out carbohydrates, a primary energy source, well below what would be recommended. She's returning to high intensity exercise, potentially too soon, while engaging in a cycle of binging and restricting. These choices are affecting recovery from childbirth and lowering milk production. This also points to disordered eating, even if she doesn't really recognize that yet. So, as a dietitian, I would start by assessing the nutrition risk and her postpartum recovery status. I like to use the eating disorder examination questionnaire to screen for any eating concerns. And I'd want some more information on her eating and on her lifestyle pattern and how she perceives her energy level, as well as the adequacy of her milk production. If I realize that there's some medical concerns to address, I would connect her with her primary care or back to her OBGYN to monitor her recovery and maybe do some lab work. I'd also want to coordinate with a mental health professional to address the body image distress and the guilt after eating, as well as the rigid thought patterns that are kind of keeping this cycle going. It could also be helpful to involve a lactation consultant if the breastfeeding is something that she wants to continue. If this were a civilian case, the same approach would really apply. The pressures could look a little bit different. Maybe it's social media pressures or intense work demands that are kind of pushing her, but collaboration is still going to be key. Working as a coordinated team is considered a best practice, and it helps ensure consistent, effective care. So for those of you in behavioral health or an education role, this is often where collaboration starts. You can have a simple warm handoff or a quick message, and that can really make all the difference. When we communicate about what each of us is addressing, whether it's the nutrition stabilization, the mood regulation, the body image, the lactation support, that's where we can help clients like Sarah feel really supported by the unified team. And this brings up our diagnostic discussion next. Many individuals like Sarah do not meet the full criteria for an eating disorder, but that does not mean that they're not struggling. And so these cases often fall under OSFED, which is a frequently overlooked diagnosis that we're going to explore next. Okay, so this next section, we're going to walk through the DSM-5 text revision diagnostic categories for feeding and eating disorders, with specific attention to how these patterns show up in military-connected families. We're going to be covering 5 of the 8 diagnoses. Many of you are already familiar with these, especially anorexia, bulimia, and binge eating disorder, but the reality is that many individuals struggling with disordered eating do not meet the full criteria for these categories. So as a result, their symptoms can be overlooked or minimized. And so we'll just be going over that today. We're going to start with OSFED and ARFED, 2 diagnoses that are commonly misunderstood, obviously still clinically important. And so you may recognize some of Sarah's story in OSFED, where the behaviors are clearly impairing, but they're falling just outside of that traditional definition. And then from there, we're going to move into the more well-known disorders. Okay, so OSFED stands for Other Specified Feeding or Eating Disorder. This is the most commonly diagnosed eating disorder in outpatient settings, and it includes a range of presentations that do not meet full diagnostic thresholds, but still require clinical attention. This category was introduced in DSM-5 to replace EDNOS, which had become kind of that catch-all with limited clinical utility. OSFED includes several defined subtypes, such as atypical anorexia, bulimia or binge eating disorder of low frequency or duration, purging disorder, and night eating syndrome. Despite not meeting the full criteria of other eating disorders, individuals with OSFED do experience similar levels of psychological distress, as well as impaired functioning and medical complications. In military-connected populations, OSFED may be especially prevalent due to rigid standards and the normalization of disordered behaviors. And so we'll take a closer look at the subtypes in the next slide. Atypical anorexia nervosa, this includes individuals who meet all criteria for anorexia. So they restrict intake, they have a fear of weight gain, they experience distorted body image, but they do not meet the weight criteria for anorexia nervosa. This is especially relevant in postpartum individuals or anyone in a larger body who may be praised for weight loss, even while they're exhibiting severely disordered behavior. Despite the absence of the low weight, medical risk does remain really high. So you can see electrolyte imbalances, bradycardia, amenorrhea, that type of thing. For low frequency bulimia or binge eating disorder, this refers to individuals who engage in all the same behaviors and experience the same psychological distress, but fall short of the criteria, the frequency or duration thresholds from the DSM. So these individuals may binge or purge less than once a week or for under 3 months, but the impact that they have on their functioning and their mental health is still substantial. These patterns often escalate if they're left untreated, and unfortunately, these patterns can be missed in settings that rely heavily on weight or the frequency benchmarks, which is why early identification is really critical here. Purging disorder is characterized by recurrent purging behaviors in the absence of binge eating. This means the person may vomit, misuse laxatives, or engage in other compensatory behaviors after small or normal meals, usually due to body dissatisfaction or anxiety around eating. It often flies under the radar, or it's mistaken as a general GI concern or even a stress-related behavior. Night eating syndrome, this includes recurrent episodes of eating after dinner or during the night. To meet the diagnostic criteria, it must cause significant distress or interfere with sleep and daily functioning. So we want to note that this is not the same as late night snacking or cultural meal timing. Night eating syndrome is often linked to mood disorders, sleep disruption, or chronic dieting, and it may be more common in individuals facing high stress or irregular schedules, such as shift workers or military families. All of these subtype presentations may not resemble the traditional eating disorders at first glance, but again, the psychological and the physical toll is often just as significant. So without intervention, they can persist for years. They can progress into more severe forms of disordered eating. That's why recognizing them very early is key, especially in a high stress environment where these behaviors could easily become normalized. Okay, next we have avoidant restrictive food intake disorder, or ARFID. This was added in DSM-5 back in 2013. Before that, feeding issues were mostly thought of as a childhood problem, but ARFID recognizes that restrictive eating can show up at any age. So DSM-5 defines it as not meeting nutritional needs in ways that lead to weight loss or poor growth. It can also lead to nutrient deficiencies, dependence on supplements or tube feeding, as well as a serious disruption to daily life. The big difference from anorexia is that ARFID isn't about weight or body image. Instead, there's there's three main patterns that you're going to see. So some people have strong sensory sensitivities where they avoid foods because of the texture or the smell or the color. Others have a low appetite or a little interest in eating. So maybe they fill up really fast or they even forget to eat. And then there's the fear-based type where restriction starts after a bad experience, like choking or vomiting or very severe GI symptoms or painful GI symptoms. To meet the diagnostic threshold for ARFID, these patterns have to cause at least one of the clinically significant consequences that are listed on the slide. So as providers looking for things like falling off of the growth curve, signs of nutritional deficiency, reliance on supplements, or avoiding social situations around food. That's what makes it different from typical picky eating, which most kids are going to grow out of. Okay, ARFID shows up in different ways, but the consequences are often serious. So in children, again, it can mean missed growth milestones, nutrient deficiencies, or the reliance on supplements to meet their needs. Adults, on the other hand, they could describe fatigue or poor concentration or avoidance of social settings that involve food. These outcomes can occur across the weight spectrum, so ARFID should not be dismissed if someone is not underweight. The three profiles each bring distinct challenges. So sensory-based ARFID, that could limit a person to only a very, very narrow list of food. And this creates stress at home. It could limit participation in social meals. Low interest ARFID looks like the client who says they're never hungry, or again, I'm full, they fill up quickly, or maybe they're forgetting to eat, which over time, that can also result in chronic undernourishment. The fear-based ARFID often begins suddenly after an event, like the choking or vomiting that I mentioned, and the avoidance often escalates very quickly, very similar to a phobic response. Any of these patterns, they're going to affect the entire household. So parents often feel stressed or judged. Siblings adapt around the restrictive eating, and meal times can easily become kind of a battleground. In highly mobile families, frequent moves can make adjustments to new environments and new food options a lot harder. And then for adults, ARFID may surface or intensify after trauma or with ongoing stress or a medical event. I like to think of a permanent change of station that could kind of be a tipping point for a family that's really going to be disruptive to a routine. Maybe they've got a good thing going at the previous duty station, and now they have to figure it all out again at a new duty station. This can add even more strain. For behavioral health providers, awareness is really essential. So ARFID can be misunderstood as gastrointestinal problems, stress, or even oppositional behavior, when in reality, the restrictive eating is driving the distress. And so early recognition and referral plus collaboration across providers helps prevent any long-term medical or psychosocial complications. And so we want to be sure that we name it clearly for what it is to help reduce any stigma around that, ease the family dynamic, and just help that individual with a path forward that's going to be effective for them. Moving next to anorexia nervosa, this is one of the most well-known eating disorders. It is defined in DSM-5 by persistent restriction of energy intake that leads to significantly low body weight, intense fear of gaining weight or becoming fat, even when underweight, and disturbance in the way one's body weight or shape is experienced. Also, the lack of recognition of the seriousness of that current low weight. The DSM outlines two subtypes. So you've got restricting type, where weight loss is going to be achieved through dieting or fasting or excessive exercise. And then the binge eating purging type, where restriction is paired with recurrent purging behaviors like vomiting or laxative use. Anorexia nervosa has the highest mortality rate of any psychiatric disorder. Deaths can occur both from directly related medical complications as well as from suicide. So again, early recognition is going to be critical to improve outcomes. The medical risks of anorexia are serious. So you could see slowed heart rate, low blood pressure, electrolyte problems, low body temperature, as well as significant bone loss that can lead to osteoporosis later in life. These are not minor issues. They can be life-threatening. They can be long-lasting. Some complications may even persist beyond recovery from the disorder. And so with psychological features, traits like perfectionism, rigid or black and white thinking, and very high levels of anxiety or depression are commonly seen. In day-to-day life, anorexia has the potential to really disrupt everything. People may just choose to withdraw from friends, from family relationships, creates a lot of strain in the family dynamic, and school or work performance could drop. Another important point is how anorexia is diagnosed. So right now, the severity is still tied to BMI, which leaves a lot of people out. And so someone can meet every other piece of the criteria, but if they're not technically underweight by the BMI cutoff standards, they may not receive the diagnosis. And so again, going back, this is where that atypical anorexia that I went over in the OSFED section, that would come into play here. The risks are still very high for those individuals in terms of medical complications, but it's a reminder that weight is not the only marker of severity, and so there would still need to be a diagnosis made there. One qualitative study looked at the experiences of siblings of individuals with anorexia. What stood out to me is how often siblings felt that they had to step into the adult roles. They described becoming protectors or mediators or even caregivers, especially when the parents were overwhelmed or if they were in conflict kind of how to handle the meal times. Some siblings talked about feeling invisible, as the family energy was really just centered around that child with anorexia, while others described carrying a heavy sense of responsibility at a very young age. So this shift in roles often created resentment, it created guilt, and a lot of lasting changes in that sibling relationship dynamic. Mothers in a different qualitative study described the illness as uncontainable. They talked about how anorexia spilled over into every part of daily life. It turned meal times into constant battles. The line between parent and child became blurred. And many mothers described feeling emotionally exhausted, like the illness was in control of the family rather than them. They spoke about fear, helplessness, and the ongoing strain of trying to contain something that really felt bigger than themselves and bigger than their resources. So these examples really highlight that anorexia is not only an individual illness, but it is a weight that is carried by the whole family. Daily routines have to change. Sometimes the siblings and the parents are going to take on extra roles or responsibilities, and the family life can really just become centered around managing that illness. So for counselors and psychologists, these findings are really a reminder to include the family in the clinical picture, not just the individual. For dietitians, they're a reminder that nutrition counseling on its own is not going to fully meet the needs of these families. When nutrition support is then combined with counseling and a family-based intervention, the chances of meaningful recovery are a lot stronger. So thinking to military families where deployments and relocations and high stress are already part of everyday life, these added challenges can feel a lot heavier. Again, early recognition and a family-focused support are going to be essential to help that individual move toward recovery and the whole household to move back towards normalcy. So next is bulimia nervosa. This disorder is defined by recurrent episodes of binge eating where a person consumes an unusually large amount of food in a short period of time and feels a loss of control during that episode. These binges are often followed by inappropriate compensatory behaviors to prevent weight gain. So you might see vomiting, laxative or diuretic misuse, fasting, or excessive exercise. Psychologically, bulimia is often linked to impulsivity, mood instability, and high rates of anxiety and depression. Shame and secrecy are also central features that you're going to see. To meet the diagnostic criteria here, these behaviors must occur at least once a week for 3 months. Another important piece of the diagnosis is that someone's self-esteem is heavily influenced by their weight or their body shape. And so the number on the scale or how their body outwardly looks really plays a large role in their perceived self-worth. Notably, the diagnosis of bulimia cannot be made if the disturbance occurs exclusively during an episode of anorexia nervosa. The lifetime prevalence of bulimia nervosa is estimated at about 3% of women and up to 2.5% of men. And while incidence rates have actually declined in recent decades, bulimia does still obviously remain a significant health concern. Medical complications are very serious, to include electrolyte imbalances, gastrointestinal injury, and dental erosion, as well as suicide risk is also elevated here. It is often hidden by the individual, which makes it especially hard to detect. Shame and secrecy kind of keep individuals from talking about their symptoms, and families might not really realize what's going on until that illness is well established. The diagnosis can also be complicated by weight bias. Research has shown that providers sometimes mislabel bulimia as binge eating disorder, particularly when the person is not underweight. And so compensatory behaviors like excessive exercise could also be missed, which delays treatment and care. Family experiences are an important part of this picture. Some retrospective studies have found risk factors such as high parental expectations, weight-related teasing, family conflict, and even self-harm. Parents in qualitative studies often describe wearing all of the hats as they try to manage care, which leaves them feeling very overwhelmed and exhausted. And so now I want you guys to consider military-connected families. These themes can take on added weight. The high expectations from parents in a military family could overlap with the military system itself. And so the secrecy and the shame surrounding bulimia make it very difficult to detect in any family, but it can be especially easy to overlook in a military household. There's so many moving pieces. The eating disorder behaviors could easily stay hidden or be mistaken for stress or adolescence or an adjustment difficulty. And so in that context, binging and purging may blend into the background until the illness becomes much more severe. So for providers, this means really looking beyond that binge purge cycle. It's shaped by stigma, family burden, clinical blind spots. And so when we recognize how the military life stressors compound these patterns and collaborate with other disciplines, then we are able to better support both that individual and their family system. The last eating disorder we'll cover is binge eating disorder. This is the most common eating disorder, but is often overlooked in clinical practice. It's defined by recurrent episodes of eating unusually large amounts of food in a short period of time and is paired with feeling out of control during that episode. Unlike bulimia, there's no compensatory behavior like the purging or fasting afterwards. To meet the diagnostic criteria here, these episodes must occur at least once a week for 3 months, and they must cause significant distress. About 1% of the population is affected, with women affected slightly more than men. Recent studies also show that adolescents experience higher rates of binge eating, and that when the disorder begins earlier in life, it is often more severe and associated with greater impairment if it is left untreated. When we look at clinical features of binge eating disorder, certain patterns come up again and again. So people often describe eating very rapidly, eating until they feel uncomfortably full, or they are eating when they're not even physically hungry. Episodes are often done in secret because of shame or guilt or even disgust that may follow. These behaviors tend to be linked with a deep sense of loss of control and distress. Another important point is how much someone's self-worth can be tied to shape and weight. So over-evaluation of their weight or their body image is not a part of the DSM-5 criteria, but research shows it is common in binge eating disorder and predicts worse outcomes. From a comorbidity standpoint, binge eating disorder has high overlap with psychiatric disorders, including depression, anxiety, PTSD, and substance misuse. Medically, patients are also at increased risk for obesity, metabolic syndrome, diabetes, and hypertension. And there's also a severe impact on quality of life. So studies suggest that people with this disorder report reduced daily functioning, and suicidal ideation is often more elevated compared to the general population. So looking at the family and military context, shame and secrecy often keep individuals from talking about their symptoms. And families, again, might not realize what's happening until this disorder is well established. Family conflict and high expectations can increase the risk of binge eating, particularly in adolescence. These dynamics are, again, very relevant to consider in a military household where military-related stress can already put additional stress on the family. In service members themselves, binge eating often overlaps with trauma, PTSD, and depression, which can worsen the clinical picture, and it could also mask the eating disorder and delay referral. Food insecurity is another additional component to consider here. It is an established risk factor for binge eating, and it affects military families in ways that are sometimes overlooked. And I'll come back to that on the next slide. As providers, the takeaway is that binge eating disorder cannot be addressed in isolation. Families and interdisciplinary teams play a key role here to help with identifying symptoms, reduce the stigma around the disordered eating, and then support an individualized recovery. Okay, so as we close the clinical overview, I want to highlight food insecurity, again, as an important risk factor for disordered eating. It is defined as a household level economic and social condition of limited or uncertain access to adequate food. 18 million US households were considered food insecure in 2023. Food insecurity doesn't always cause hunger, but it can be an outcome. And recent research shows that individuals who have gone through regular periods of food insecurity are more likely to engage in several disordered eating behaviors. Research shows it increases the risk for binge eating disorder, bulimia, and OSFED, the cycle of scarcity and abundance where families restrict, and then when resources are limited, and then overeat when food is available. This can reinforce that loss of control with eating over time. Food insecurity is also associated with more severe eating disorder symptoms. So adults experiencing it are more likely to report compensatory behaviors like purging or fasting, along with greater levels of distress and impairment. The findings are a little bit mixed for adolescents, but some evidence suggests that early exposure to food insecurity increases the likelihood of eating disorder symptoms later in life. Food insecurity is a significant issue in the military. I've seen that firsthand. Before the pandemic, nearly 1 in 5 Army households were food insecure, which was similar to the civilian side of things. But with the onset of COVID-19, that number jumped to 1 in 3. And so while many families do remain food secure, this shows how vulnerable military populations can be to disruptions. Relocation, spousal unemployment, and income changes are already very common in military life, and it can easily disrupt life in a similar manner. So it's important to consider how quickly those disruptions or instability can affect eating behaviors. I'm going to take a few questions if there are any, and then I will pass it over to Ryan for this next section.
Thank you, Captain Gunnarsson, for that great clinical overview. That was really helpful. We do have one question in the chat that you might be able to answer right now. When you were reviewing the case study of Sarah, you mentioned the eating disorder questionnaire, EDEQ-6. And so the question is this the standard recent questionnaire?
It's what we use in my clinic. I can't really speak, I guess, to maybe what is being used on the psych side of the house, but that is what we use in our clinic here.
Great, that's helpful. We don't have any more questions at this point in time, so I think we'll go ahead and proceed with Captain Farley's section of the presentation. But to our audience that's with us today, please know that you can post your questions in the chat pod, and we will have additional time for questions near the end of the webinar.
All right. Thank you, Bethany. Thank you, Brooke, for all that tremendous information so far. Again, my name is Ryan, and the next few slides that I'm going to focus on are going to dive more into the treatment process of eating disorder patients. An eating disorder patient's care will not be managed and really can't be managed by just one provider. It really takes a full team to allow the patient to get the most effective treatment. All the providers that may be working with an eating disorder patient serve a different role to the treatment process. However, collaboration is greatly encouraged and very necessary to form the best course of action for the patient's care. Providers that you could anticipate being involved in the treatment process would include therapists, dietitian, psychiatrist, primary care doctors, occupational therapist, and social workers. This isn't to say that there couldn't also be other potentials involved in the care, but from my time in the field, these tend to be the most common ones that I've come across when working with patients. So to break down what each of these roles really encapsulate, we'll go through step by step for each of them. So the therapist tends to be the outlet for patients to talk and work through problems with. This can be done, of course, in one-on-one sessions, but therapist-led group sessions can also be tremendous assets to the recovery process to allow patients to learn from their peers and to build a community for support within recovery. With the patient's permission, this info can also be relayed to the team in order to help drive recovery in needed areas. Um, Through sessions, they also tend to help uncover underlying issues that are brought on to eating disorder. I know this combination of roles is such an asset to the rest of the treatment team. When you have some direction to work with prior to sessions or appointments, it could really help give you a head start on laying down that recovery path to travel down with your patient. A therapist can also help assist with establishing coping skills outside of eating disorder or behaviors. Reading, music, breathing techniques are all ones that I've seen been used with patients that I've worked with. The therapist also would tend to be the provider the patient is seeing the most. So for the team, a really good therapist makes the entire treatment easier for all parties involved. I've also seen them act as an advisor for the patient, kind of motivating them to engage or make appointments with other providers, especially if they're lacking on that side. Uh, Dietitians, we're going to focus more on managing intake, what is being eaten, what is not being eaten, what is being drinking, what is not being drinking. This could range from setting goals for meals, snacks, meal prep, calorie ranges, but also finding solutions to eating disorder behaviors, whether that is restricting, purging, or binging. The goal of a dietitian is to work with the patient in order to figure out doable solutions to correct intake and continue to make the eating process as natural as possible for the patient. Uh, this will involve managing and treating malnutrition if present. So malnutrition isn't always noticeable and does not present itself how we might envision in all patients. If indicators are present, it is important to treat it in this role, but also communicate it to the team, especially if you feel like there's a higher level of care that is needed. Our psychiatrists are going to be involved with prescribing and managing medication. So many behavioral health medications can come with the side effect of affecting weight and appetite. So the regulation of these medications can be a challenge at times when working with eating disorder patients. But many of the psychiatrists that I've worked with have been extremely accommodating to the patient to be as open as possible to making sure that their needs are being met without doing their best not to trigger the patient in any type of way. It is a challenge, but if there's usually a solution to those problems when we come across them. Your primary care physician or doctor is ultimately in charge of managing the care. They may be seeing the patient the least out of all the providers kind of listed here. Their appointments may be more 6 weeks, bi-monthly, quarterly, depending on their schedules. So gathering that info from the teammates is going to be really important to make sure you're getting the most informed decision. But the decision for a higher level of care ultimately will come down to the doctor. A psychiatrist can step down into this role and sign off on documentation if needed. But ultimately, regardless if it's psychiatrist or the doctor, paperwork for treatment or for a higher level of care ultimately needs to be done by the doctor, and that's one of the biggest roles they play. Your occupational therapist, their role is really retraining the patient. So eating disorders can become so consuming day to day that stuff we take for granted can be monumental for them. This could be healthy hygiene patterns, finding a daily routine, proper time management, retraining how to eat, amongst many others that I've seen in collaboration with OTs. And I think a side note that I think is important to highlight is that of all the current patients that I work with, all of them really seem to have a great connection with OT. and this has been a trend throughout my career, I think besides just them having just tremendous providers in that field, it does appear that occupational therapy allows these patients to start to reclaim some level of normalcy with their daily lives, knowing how much that the eating disorder kind of controls day-to-day steps. And this may be different from directly attacking the issues that, say, a therapist or a psychiatrist or a dietitian may have to do with their type of care. And then finally, social work helps a lot with care coordination and patient advocacy. For care coordination, it could be assisting with appointment coordination, especially if appointments can be made within or without the military healthcare treatment center. They would also be involved when it comes to assisting when a decision is made for a higher level of care, whether that is family assistance, finding the right fit for a program, paperwork, transportation. I've seen social work be involved in many different facets along these processes when it comes to eating disorders. So to piggyback off of that, you can also be working with providers within the military healthcare system and those outside it. Every base or treatment center is different. Some patients get everything done in one place, but others may need a combination of resources. It can be difficult at times for those that have not experienced or been around the military to understand all the nuances that come with the lifestyle of the military from either the service member or the dependent's viewpoint. This is where collaboration is going to be key. On both sides, you can view the same situation very differently, which can be an advantage to the treatment process. On one hand, you could potentially catch stuff that the other can't from their viewpoint, while on the other hand, if something does not seem right or seems off, you have that resource readily available for you to kind of just check in to clarify for you. So again, you've heard it a few times already, but collaboration is going to be key. So sessions or appointments with eating disorder patients tend to be a bit unique compared to working with patients who don't experience the same struggles. Eating disorder patients affect a wide range of individuals, male, female, different body sizes, many of which don't fit the stereotype you might immediately think of when it comes to an eating disorder. This can sometimes cause issues for those who on the surface don't appear to have an eating disorder to get the care they truly need. So as already mentioned, this is where the interdisciplinary collaboration is going to be very key in order to try to make sure we get all those individuals the care they can get. Patients tend to have a lot of knowledge when it comes to eating disorders. When it comes to nutrition, dieting, calories, they can often be very open about also knowing what they are doing nutritionally isn't what their body needs, but just have this inability to be able to do what is right for their health. Treatment is never a straight path. Patients will almost certainly have hiccups and backslides in treatments. Rebounding and moving forward is key while using these experiences as learning tools to help set solutions for problems in the future. And then patients can also often find meaning or validation in their eating disorder. Eating disorders can become their identity, and eating disorder community can be a good one, especially for support, but also can present a level of toxicness when it comes to validating these behaviors. Patients can find eating disorders as a source of accomplishment and also as a level of perseverance on how far they've been able to push themselves, while others may use it to always be viewed as sickly or needing help as a means to be potentially coddled, which we would want to avoid in care. The approach that I was always taught, and especially from working in the treatment center, was to approach these patients with empathy, but not sympathy. Empathy for what they have had to endure through their eating disorders and the challenges they've overcome, but not sympathy in a sense of not feeling sorry for them. The more we feel sorry for them, the more, it can lead into those type of feelings. So the more empathy we can, it's just better off working for them. Right. So patients may also be in this limbo period of where their care should fall. Some patients may exceed one level of care, for instance, outpatient or a partial hospitalization program, while also not meeting the criteria needed for the next level of care, for example, inpatient or residential. Many factors can play a role into these situations, such as insurance, doctor recommendations, treatment facility acceptance standards, or even the patient's awareness or acceptance. As a provider, your goal is to continue what you can to assist the patient, along with working to advocate for the care you believe they may need to best succeed. And then finally, within treatment, regardless of provider, the role you may find yourself in, everyone's going to have a viewpoint on the patient from a different lens. This can be very important for the overall success of the recovery process, but also can result in things being slowed down at times due to differings of opinions on the patient status. It is important to still advocate for what you are seeing from your provider lens, especially if you feel like more care is needed. Guidelines listed here can be helpful for determining if your inclinations are aligned with recommendation practices, along with being able to use these resources to provide to other providers who may not feel the same way that you do. So we have our roles and our background information. Next, we want to set the stage for successful care. As discussed, eating disorders are complex mental health conditions. A sound treatment plan may be present, but may not yield the results that you'd hope. And sometimes deviations might be needed in order to move care along appropriately. A patient's current mental state can very much play a role in slowing down or simplifying care to best help the patient in the moment. We mentioned dietitians. I can speak from experience being one myself, but many providers we have listed when it comes to eating disorder patients might need to lean into more of their counseling skills than specific specialty skills. I wouldn't say this necessarily means we need to assume the role of a therapist, but sometimes listening can be more beneficial to the patient than talking can be, along with allowing you to get a better insight into where they are mentally to decide the best course of action. However, it's still important to incorporate and ultimately work towards evidence-based practices. This is where goal setting to allow patients to incrementally work up to standards can be such an asset to the overall care. It is also important to highlight that eating disorders often are accompanied by other psychiatric conditions, including the ones you see listed on screen. Each of these can impact the plan of care and how goals are set up. Optimize good days, simplify harder days. Having a plan for both sides of the coin, depending on how the patient currently is the best way we can kind of help them get set up for success and move past current situations. In addition, treatment overall for eating disorders can feel like it follows its own set of guidelines, as treatment can change rapidly on a dime. For example, a patient may need to have caloric intake monitored closely when refeeding starts to avoid refeeding syndrome, as renourishment can almost shock the body. Not soon after, you can be on the opposite side of the spectrum, needing to increase and continuously increase calories as metabolic starts to wake up. Sometimes intake can't meet needs, or depending on a pace of refeeding, supplementation might be needed, while sometimes supplements like Boost or Ensure can be used as crutches for patients to avoid truly eating and should be avoided. Even with weight and calories, both are indicators of progress and are used in care to determine the next steps, but also in many cases aren't talked in depth about with the patient to avoid preoccupation or feeding into the importance they may hold in everyday decisions. The pattern you can see in every case is going to be a bit different, but this again highlights why collaboration is so crucial with these patients, as recommendations can change from one side of the spectrum to the other, while some needed can also be working against them. So every member of the team being on the same page is going to be super vital to make sure we're moving in the right direction. And a final note as well, when it comes to care, eating disorder treatment can also be done in and worked in many different facets and find different success. Group sessions, support groups, psychotherapy sessions, exposures therapy, family sessions can all be used to success and shouldn't be shied away from if conventional one-on-one sessions don't seem to be working for you the way they should be. So I've mentioned it a few times, but so when we talk about levels of care or higher levels of care during this presentation, we're referring to the different stages of care an eating disorder patient could be going through. So starting at the lowest level would be outpatient care. This could be treatment facility or providers with private practices, but this would be more along the lines of follow-up maintenance calls. But within the military healthcare system, this could also be the starting point for a newly diagnosed disorder or for someone suspected to potentially have one. Next level would be intensive outpatient program, usually referred to as IOP. This is usually held at a treatment facility where care is received. This could range from a few hours of care to a few times a week. This allows the patient to maintain daily life and routine while also still maintaining a level of support. This would be followed by partial hospitalization program, often known as PHP. This level is designed for people who require more support than an outpatient program can provide, but do not require 24-hour care as an inpatient setting may require. This usually would be 3 to 5 times a week, 8 to 10 hours a day with the program, where you will usually do a combination of meals and snacks, which are monitored along with meeting with your interdisciplinary team for treatment throughout the week. Residential treatment would be the next step. Residential can be thought of similarly to like a rehabilitation center. The focus of these centers is to work with patients to reintegrate them back into daily life. They will still receive treatment from an interdisciplinary team while also focusing on life skills such as cooking, healthy coping skills, creating non-eating disorder behavior-esque hobbies. Many of these programs utilize different therapy methods as well in order to help make breakthroughs in treatment and find routes to success maybe not explored before, such as a facility in Arizona called Montanito. They use equine therapy, which is utilizing horses, which I think is super cool. And I've seen success from that. So I think it just kind of proves that any therapy can be used to kind of really make a step forward. And then finally, highest level care is inpatient. This is the one we often think about when it comes to or hear about eating disorder patients. Short-term, long-term hospital care with round-the-clock treatment and monitoring. Patients will have an interdisciplinary team that they see daily or weekly, depending on the specialty, with the goal of stabilization and weight restoration. Entire days are monitored and planned out from school, depending on their age, group classes, therapy sessions, medicine, meals, snacks, everything is very standardized. Criteria can vary from facility to facility, and word can travel amongst the eating disorder community on the goods and bads of each of these places. So finding the right fit for a patient can be tough at times, but ultimately many of these facilities follow the same blueprint. So at the end of the day, they will accomplish the goal that we need them to accomplish. It is not uncommon for an eating disorder patient to move up and down in the level of care throughout the recovery and treatment journey. Some patients may never hit all levels, but having an idea of what each level involves is smart to know about, especially dealing with long-term eating disorder patients, as they may often refer back to their different times at these stages during their recovery process. So now we have an understanding of the different levels of care. Let's discuss what happens when you realize the care currently being provided at your level isn't enough. When making determinations on whether a higher level of care is needed, the following are some of the indicators you'll want to consider. If you are noticing weight or BMI or current intake are all decreasing or at an unsustainable level, if there is an increase or evolution in their eating disorder behaviors, if their nutrition-focused physical exam comes back indicating malnutrition, all these are indicators. And if all these signs are pointing to the same direction, that could mean that there's a higher level of care that's needed. The team should be involved in this process. If you are in communication with each other and all or most of the team are noticing similar concerns, that could be a good time to have the discussion. Some members may see things differently or want to wait for certain indicators that they use to make the determination, but there is nothing wrong with bringing the awareness as a provider to highlight concerns you are noticing within your discipline related to the care of your mutual patient. Overall, paperwork signing off on will ultimately come from the doctor. Sometimes the doctor, however, may not be working with the patient at the same frequency or on the deeper level as, say, the therapist may be. So it is important. That's where the collaboration and the teamwork are going to come. If all providers are doing their part in documenting the trends, this allows the doctor to make the easiest decision and for the whole team to be on the same page. So if the decision for a high level of care is decided upon as a team, ultimately the next step is to relay this decision to the patient. I don't necessarily think there is a specific provider that should be the one fully responsible to tell the patient. In many instances that I've been in, it tends to be the next one that they see. It can be done as a team, or the team decides on the route which they feel makes most sense for the patient to get the buy-in, especially if they have a level of trust with one of them that's a little bit higher than the rest of the team. Biggest thing is to just make sure that everyone is on the same page. If not, this can definitely result in breaks in trust between the patient and the provider team. Overall, the responses might be different depending on the timeline of the eating disorder. If this is a newer patient, this potentially could be the first time this conversation is happening. Approach this with empathy and compassion, as the amount of thought that could be swirling around their heads could be a lot at that single time for them to handle. I would expect a wide range of anticipated responses: anger, frustration, betrayal, sadness, a level of scaredness. I would expect tears, along with an immediate rejection, along with different reasons on why that rejection may be the case, right? It could be due to military obligations or their family or security clearance, nervousness, the stigma that would come with that. But it's important to highlight the benefits of what more advanced care could do for them currently and long term, along with reassuring them that as a team, you're still there to support them during this transition. On the opposite side, for your long-standing eating disorder patients, this could be the case, but often it shouldn't be a surprise that this conversation is coming or happening. Immediate response could be rejection to a higher level of care, or potentially a threat to or a desire to find a new provider if they truly don't want to go. However, especially if they are, been working with you for a while and there's a connection and a level of trust built between the team and the provider and the patient, acceptance to the decision should ultimately come. This is where they may call upon past experiences to indicate certain facilities that they refuse to go to, usually based off past negative experiences that they personally experienced or that the community members have experienced. And that's where, as a team, you just try to help them to find a better fit. So let's transition to one of the biggest talking points in medicine right now, especially when it comes as a dietitian, right, personally, is weight loss medications. Whether it's Ozempic, Wegovy, Mounjaro, all of these, right, are used in some capacity for diabetes management, but their big and popular reasons for using them now is for weight loss properties. They're some of the most sought after medication by patients, and with eating disorders, it's no different. These medications are very new, right? And they're used for weight loss. So long-term research and conclusive evidence-based practices are hard to come by. Because of this, there is a need for proper education when it comes to these medications in the treatment of eating disorder patients to ensure they are appropriate and support the recovery process. Even with these efforts to protect patients, this could all be a moot point with these medications becoming more and more accessible through different means. Again, right, just mentioned long-term research on these medications, particularly when it's related to eating disorders, is very hard to come by. But the following list are some potential risk factors that eating disorder patients could experience when using these weight loss medications, many of which could negatively impact the recovery or the treatment process. Overall, when it comes to treatment guidelines, caution should be taken when it comes to these medications with eating disorder patients. For diabetes management, these medications can be very helpful, but with these medications being specifically sought after for weight loss purposes, there is just not enough evidence, and we can't confidently prescribe them to eating disorder patients, especially with the mentioned risk factors we just had. Hopefully in the future, we'll continue to get more research on that. But I think we just got to play it with as much caution as possible when we talk about right now in the current time frame. All right, so let's dive into a case study, right, to kind of put some of these past few slides into action. So this case study centers around a 22-year-old male who is the dependent of an active duty soldier who's being his mom. His current height, 5'6", his weight, 126. At his lowest, he's been 97 pounds. At his highest, he's been 150. His background information. So he has anorexia nervosa, he has OCD, he has GERD, and he has psychoaffective disorder. The patient is currently unemployed, is not in school, and lives at home with his mother. He has been in eating disorder treatment for over 3 years, which has included 3 trips to an inpatient treatment center and 3 trips to a PHP center. He is currently utilizing outpatient care for his treatment at multiple different treatment facilities. A bit more history on him. This eating disorder is believed to have started his senior year. The patient is currently using binging and purging, restricting, and calorie counting as his eating disorder behaviors. But in the past, he has also used a history of laxative abuse, extreme exercise, and unorthodox diets. Some of them including a soy sauce diet and a Tic Tac diet. So he's gone very much down the rabbit hole of trying to find different resources to try to achieve the goals that he wants. Some of his symptoms, he's been passing out. He has a lack of gastrointestinal tract control, memory loss, and hair growth from eating disorder. Part of the thing that works against him is he doesn't have a really great support system at home. His mother is the only parent in the picture right now, and they have a really big disconnect on his eating disorder. There's frustration between the two that's very visible, and it really is based on what she feels like he isn't doing enough to help himself, and he feels like his mother doesn't understand him when it comes to his eating disorder. With all the background information known, let's kind of discuss where the patient's currently at. He was recently discharged from an inpatient treatment facility here in the DMV called Prosperity, and needs to now rework to rebuild his treatment team. The issues he's experiencing are he was discharged directly to outpatient care. So if you remember the scale that we had, that's from the highest level all the way down to the lowest level. Ideally, he would have wanted to drop down to a PHP or residential, but insurance rejected those offers. So he had to bounce right down to the lowest level. This kind of means that we need to act relatively quickly in setting up his treatment team to avoid any kind of backslides or relapses in his care. Another issue is he actually recently just moved. So for him being in the military, that means that some of the team he was seeing no longer he can see due to travel restrictions or due to where he's currently set up at his base. What he does have on his side, however, is that he can return to the care of his dietitian and his doctor, and both of them are located within the military healthcare system. So, question that would be proposed would be, how do we assist the patient in order to continue his recovery as needed? So if we were to think about some of the big themes that we talked about in some of these past few slides, right, I think that's where we can really find our answer. As mentioned, eating disorder care involves an interdisciplinary team, and at this time, he doesn't have one. So the goal would be for an immediate kind of response to try to find him a therapist and a psychiatrist so he can get his medication regulated and he can continue with his therapy. I also think occupational therapy would be tremendous for him, especially knowing that he's coming from a long-term inpatient treatment. I believe last time that we checked, he was in there for 3 months. So that transition home, and especially moving, it's a lot that he's going to have to relearn and redo. So that occupational therapy could be a real great asset to kind of get him better situated at home. And then, as you kind of heard from the background information, a social worker could be a great resource for him as well, especially knowing that his support system at home is a little shaky. So whether that be, additional resources, assisting with advocating for the patient or assisting with care coordination, all those can be really great. So especially knowing that he has 2 providers, right? He has a little bit of a leg up. But one thing we'd also want to think about too is since he moved, right, this could result in the patient having to find resources inside and outside the military healthcare system. If this, right, is the case, right, what it would be important for would be for him to potentially lean on his 2 resources he has now, his dietitian and his doctor, to potentially assist with that, whether that be for referrals, whether that be for just care coordination, but also to make sure that if he's using providers outside the military healthcare system, that they have some background information to work off of, right, if they're not have any type of history using the military healthcare system. So in conclusion, right, working with eating disorder patients can be difficult at times, right? Learning about their traumas, seeing their struggles, feeling at times you aren't making a significant difference. But once you are able to build a connection and get buy-in, the work can be extremely rewarding. You'll be able to start to see noticeable differences in morale, personality, and outlook on treatment, and more importantly, life. Like also from my time in the field, eating disorder patients have been some of the more grateful patients as they often acknowledge how difficult the care is working with them, while often being very apologetic but appreciative for everything you might have to encounter during these sessions. for me, it's always been seeing individuals who were once so consumed by their conditions regain their passions and excel at their careers. And when you have success with these patients, they become your biggest spokespersons. Since you have championed them in recovery, they will always pay it forward and highlight your efforts. And finally, working with eating disorder patients and finding success, it just feels a bit different compared to other patients. Um, we all become providers to help others in some fashion. And while helping someone potentially achieve one of their goals is a great feeling, but helping someone reclaim and ultimately save their life is just a very powerful experience. I hope this presentation has provided you with some insight or guidance that can help you in your profession. And I encourage you, if you have the opportunity, to please, try your best to help in the community. And thank you guys for all your time.
Thank you, Captain Farley, and thank you again, Captain Gunnarsson. This has been really informative, and we appreciate all the time and effort that you put into this presentation. And you'll see in the chat that people are chiming in that this was excellent. We do have a couple of questions that that came through during the presentation. The first question is probably for Captain Farley, as it relates to weight loss medications. If patients are already on weight loss medications when they come to you for eating disorder treatment, how do you go about addressing that? Do you follow up with their primary care physician to suggest discontinuing the medication, or is there another approach that you would take?
No, so I've experienced this a few times actually recently. So the thing that I've done is I definitely contact the doc, right, just to kind of get an idea of one, if they're tracking, right, from an eating disorder perspective, and the majority of both of them that I've worked with have, but just trying to get the reason why we decided to go that route. In both cases, it very much was leading more towards PCOS. So what we did on my side from an eating disorder perspective was really just trying to make sure we were monitoring it. And I think the good thing was that neither of these cases were newer patients. They were long-standing eating disorder patients that have had it for X amount of years. I think the thing to highlight that I saw with both of them, though, and I think it's something that hopefully research will come with, is that both of them were in bigger bodies and saw great success from it, right? And both had binge eating disorders. Weight loss was a goal for them ultimately. So we actually saw some success when it came to their binging disappearing. But right, if you have any background with these medications, right, they some plateaus will be hit at certain times. And I think that's where I saw a lot of the downside to using them with eating disorders. Was it was almost, we saw a reverse from starting with binging to then switching more towards like an anorexia mindset of you tried for so long to get this weight loss, you have this weight loss, then you hit this plateau, or that plateau results in you slowly gaining a little bit of weight. Then you see the behaviors from the opposite side of restricting. And I think it's just making sure that you're being aware of it and being in communication with their docs. Both the docs I worked with on that side were very much involved and were working with us. And I think it's just the problem is just so new. It's just so new that we don't have that background information to kind of lean on. So we're kind of learning as we're using these medications.
Thank you for kind of answering that from all angles. Next question, I think either of you could chime in for this one. This comes from a person who works with veterans that participate in the VA Move weight management program, and some of their veteran patients ask about how to stop quote unquote food noise. What would be your response to help them work with patients who ask that question?
Hey, I can take that question. Ryan can chime in if he has anything additional. That's a great question, first of all, because I experience that with a lot of the patients that I see. They'll bring that up, maybe not in those words, but I like to always just kind of explore what that means to them. What does food noise, I guess, mean to them? For some, that's going to be like they're preoccupied with their thoughts about food. Maybe they're preoccupied about the weight or just eating or when's the next meal. And so I just kind of like to get their perspective on what does that mean to them, because it is a little bit different. And so I definitely will take an individualized approach with a statement like that. From like a behavioral nutrition perspective, I think I see those thoughts get a lot louder if the body is being underfed or overly restricted. And so when you are having that patient that's engaging in some of these maladaptive coping behaviors with their disordered eating, I think you're going to have that food noise be a lot more persistent. And so I guess from my standpoint as a dietitian, I would just kind of see what that means to them, and then go into what is underlying, like what is driving that food noise to be so loud right now. And so then ensuring if they are eating enough, are they eating consistently throughout the day? Are they eating a variety of foods that's stable for them and allowing them to be leading a life that has good quality to it? And so you might be working then on that more specific nutrition piece where you're doing true nutrition counseling, but then bringing that back to avoid like future food noise. I would probably work in some mindful eating strategies. I'll often tell patients to journal, or maybe slow down at meals, kind of in like truly enjoy their food that they're eating. Listen for hunger, fullness cues, that kind of thing, instead of listening to whatever that food noise is telling them. Sometimes going on a walk or doing something with your hands to kind of just be motivated by something else. So that's my perspective on it. I don't know if Ryan has anything else.
No, I think I align with you really well. I think the only other thing I was going to add would be, I think looking at all the different sensories that kind of come into eating, right? I think we just really focus on, right, our eating process, but looking at our environment potentially to see if there's anything that's throwing you off, right? I think setting yourself up for the best success is definitely one of the things I try to push with all my patients is, if you're really trying to focus on blocking everything out, then some of that noise can really creep in as you're trying to just solely focus on the eating. So making sure that your environment that you're eating in kind of suits you and fits you just kind of helps reinforce and keeps you as calm as possible when it comes to those eating processes.
Thank you both. I think we have time for one or two more questions. And another question came through in the chat pod that's asking if either of you have experience working with other providers within the multidisciplinary team. So maybe a primary care physician or a mental health professional who are maybe not well versed in disordered eating and might actually be normalizing the disordered eating behaviors. And the person asking the question says, we try to provide as much education as we can, but it can be a challenge to convince the other providers that those behaviors are not normal. So do you have any advice for those providers who might be in a similar situation?
Yes. Have I experienced it every day? And I think some of it, I always hope is not intentional. Right. I think some of it is just misinformation. But I think some of it goes down to, at the end of the day, how much does that provider believe the patient? Right. I think we've all been in different situations where we've heard something in a session and it's just like, yeah, that's not what happened type deal. But I think many eating disorder patients come into situations feeling like already they're not going to be listened to or not going to be heard, right? Even we could think about, right, very, very common in the military healthcare system, regardless of what you're going for, right? You can go for behavioral health, you can go for, just get an ear infection, right? But you may get your height and weight done immediately the first thing, right? Patients may tell a provider, hey, I really appreciate not to do that, but being ignored right then and there, right, is going to start the process off on a bottom of trust. So something I always try to do in like my first bit of sessions with the patient is like, well, what are some things that are bothering you? What are some things that we can try to do from a provider standpoint to help make your recovery journey as easy as possible? And one of the things they'll mention is very similar to that in a sense of, I feel like this doc or I feel like this provider, if they're comfortable enough to tell me exactly who it is, through the portal that we use, you can contact pretty much any provider in our electronic healthcare system. So I'll reach out and just be like, hey, I've experienced this with the patient. She kind of told me, do you have time to chat? Do you have time to just so we can kind of be on the same page? We can try to help. Very much, a lot of these docs are open and a lot of the primary care physicians are open. And then, right, if I wouldn't be afraid to make sure I'm setting the patient up for success if I do talk to this doc and I get the perception of, yeah, it is what it is. Like, I don't have time to really like put everyone's needs, in place. Right. For me, that kind of is an inclination of like, all right, this is not the right fit for this patient. So that's something where I go back to the patient and be like, look, I talked to the doc and I try to be as professional as possible in those leans, but I always don't try to, sugarcoat in a sense, just like, hey, you may want to just talk to your team about trying to find a doc that fits you a little bit better. Right. We're both on opposite sides of the spectrum. It's not his fault. It's not your fault. Just so I can make sure that, hey, I'm not setting this patient into, the fire every time they have to go and get an appointment, or even thinking about it from the perspective of, hey, if this is the doc I have to work with to ultimately get a higher level of care signed off on, and they don't believe this patient at all as it is, it's going to affect the rest of the care, right? So I think about one of the slides I went with is just, hey, if the whole team isn't on the same page, it's not going to make sure that the care is not going to work the right way. So I think that is ultimately trying to make sure that all providers are kind of looking at the patient from the same lens.
Thank you. Oh, Brooke, go ahead.
Sorry. I agree with everything that Ryan said. I guess just one other thing from like a collaborative lens. So we think about shared goals and how that's a huge part of professional collaboration. And so I think if there's a way that you can kind of identify, okay, what's a place that we can share a goal here? I think we all could agree that we want this patient to be safe. And so using that patient safety side of things of, hey, I see what you're doing. I think maybe going this route would be a better option for that individual. And you don't have to necessarily use the words patient safety, but I think showing that that's your goal for that patient is something that's safe and going to benefit their quality of life or their health or whatever that may be, to create a shared goal that they are likely to also have, they might be a little bit more motivated to kind of shift whatever they're doing to align better with what you see as best for that patient.
Thank you both for your presentation today and for your comprehensive answers to the questions that we have. For the sake of time, I think I'm going to go ahead and go through the CE information just so people can get their certificates. The next few slides are resources and the reference list for this webinar, and a link will be shared in the chat pod to access all of these webinar resources. For this session, 1.5 continuing education credits are available from the American Association for Family and Consumer Sciences, the University of Texas at Austin School of Social Work, the Commission for Case Manager Certification, the National Council on Family Relations, the Patient Advocate Certification Board, the Commission on Dietetic Registration, and the National Commission for Health Education Credentialing. A link has been shared in the chat to the webinar evaluation and to receive your continuing education certificate. You may also visit the webinar event page to obtain your certificate. On the event page, you will find a purple continuing education link. After completing the evaluation, you will be directed to select the appropriate CE opportunity, complete a post-test, and fill in your name and email, and your certificate will be emailed to you. Please note that some email addresses direct the certificate to your spam folder, so please check there if you do not receive your certificate. If you have any questions about your certificate, please contact us at the email listed on this slide, ce@oneop.org. And as a reminder, a recording of today's session will be archived within 48 hours to our YouTube channel, which you can access via the event page. OneOp would like to invite you to a webinar on October 14th titled Nourish to Flourish, Nutrition Strategies for Breast Cancer Survivors, presented by Whitney Warminski, a clinical dietitian at BSA Harrington Cancer Center in Amarillo, Texas. And the registration link for this session will be placed in the chat pod. Additionally, OneOp would like to invite you to another webinar on November 12th titled How Zip Codes Shape Your Health, Mapping Determinants and Outcomes. And this will be presented by Dr. Morgan Foster, an assistant professor and extension specialist of disability and health at Texas A&M AgriLife Extension Service and Texas Council for Developmental Disabilities. And we will also put the link to register for this webinar in the chat pod. Please be sure to visit us at our website, oneop.org, to explore upcoming events, articles, resources, and more. You can also find us on Facebook, LinkedIn, and YouTube. We will stick around for a few more minutes for those who might need to grab any links or information from the chat. Thank you again to our presenters for such a wonderful session, and to all of the attendees and for your great questions today. We hope you have the great rest of your day, and we'll see you next time.